Okay, so my name is Asmyr Thorseng. Thank you very much for inviting me. This is a very, very exciting topic. I come from the University of Oslo, where we make one of the largest health information systems in the world, a little bit unknown to many people. So that is what I will talk about today. So our focus is on information for action, so enabling people to have access to relevant information to make good public health decisions, particularly in developing countries. And we also have several activities around COVID-19 at the moment, which is interesting. We don't really have a particular focus on machine learning or AI, and I'm not an expert in that topic. So I'm also very interested in your feedback when you listen to how we work. If you also have good insights to how we can more utilize that part of technology development. But I hope it'll be interesting to understand how health data is collected on a global scale, and it informs also COVID work. So the Health Information Systems Program, this is a big global network of people, of academics and practitioners. We have a base here at the University of Oslo, but we're a truly global team with hubs all around the world. And our main activity is to develop a software called the District Health Information Software. Number 2 means that it's version 2. It's not the most sexy name, but now it's an international brand, so I don't think it will be changed. This is an open source software platform that started to be developed in the mid-90s as an academic project. It was someone's PhD project at the University of Oslo at the Department of Informatics, where they started in South Africa to collect health information. Now it's a truly global community of developers, implementers in the world. You can see the map below. That's national ministries using DHIS2 for collecting their health information and to building their national health statistics. So it's important work. And the use cases are mainly in health, but we also do work in some other domains as well. We're starting to move into the education sector. So instead of counting the number of children vaccinated, you could also count and do analysis on the number of children in school and the number of desks and classrooms, for example. It's sort of the same use case, it's just a different domain. But mainly we work in health. We're financed by a range of big donors. NORAD from the Norwegian Aid Agency or something. I don't know what the English abbreviation is. And then other big international donors that work in the public health domain. Gavi, particularly relevant now for COVID, where they work with vaccines. Bill and Melinda Gates Foundation, the Center for Disease Control and Prevention in the States. And we're also a collaborating partner with the WHO. So we have sort of arms and legs into all of these big bodies that are doing policy work and doing work on the ground as well in public health. And we provide digital support to support the work that they're doing. So I was thinking I'll take you a little bit through how health data is collected in developing countries. Here in Norway, at least, we're used to going to the doctor. Everything is pretty digital. You put something into the computer and you can say a lot about the shortcomings of the digital technology in health also here in Norway. But in many countries, the reality is that healthcare is provided, often quite close to the community. So mother-child health, outreach services, treatment for malaria, tuberculosis, HIV is provided quite close to the communities. And here health data is quite often collected on paper. So you can see the picture here is a nurse weighing a baby, and she notes down whatever she's doing in a booklet. Often the mother would maybe carry a booklet with her, or she just shows up, and then the data is collected analog on paper. This is also from Ghana. So here you can see people plotting in information in huge booklets, where they typically have their work schedule and they're working here throughout the day. And then at regular intervals, the data is entered into DHIS2 on any device. It can be a cell phone, or it can be a laptop or a tablet. So here in the picture here, you can see this is a tuberculosis coordinator in Ghana. She's entering this week's data or this day's data into DHIS2, the paper form here. And she's showing me how she's doing that. And the man next to him is working with antenatal care data, which is mother-child health data, pregnancies and such. And here you could, the data can be validated by set validation rules, so you could see if the data is valid or not. So typically, like a data officer, for example, a district statistical officer will do the data entry, the data validation, ensuring that the data is correct, that it's not cooked, or that it's not a lot of typos and errors and outliers. And you could also do a range of different analysis on the data that he or she would present to program people, for example, the person responsible for malaria in the district, to see that the changes from one month to another, do you need to make any changes in how you provide healthcare? And you can present data in a range of different dashboards to show your indicators. So DHIS2 supports visualization of data and indicators in a myriad of different ways, and the challenge is just to present it in meaningful ways. That requires some training, both to build the dashboards and also to understand what it makes sense to highlight. And as you can see on the picture here, we also support maps. And this is pretty useful now for pandemic situations such as COVID, but also for cases such as malaria, cholera, measles, where it can support the detection of hotspots or outbreaks visually and geographically. So it's also worth to say that we do collect data, or the software supports collecting aggregate data, which is counting the number of children, for example, that get a vaccine, or you can track them individually, which requires a lot more implementation-wise, and you need a lot more devices and training, and the costs are higher, and the complexity of the project rises exponentially, basically. But it will give more granular data, which can give more interesting analysis. And you can also link data to logistic modules, for example, to see correlation between vaccine coverage and stock of vaccines, for example, to, again, point out where you need to make changes in your health system. So in these COVID times, we have developed modules to support the work around the COVID-19. So this winter, as the first case of COVID hit Sri Lanka, they were the first team to turn around super quickly and to make a configuration on top of DHIS2 to support COVID, to handling the COVID pandemic. So the first thing that they built was a system that could easily track people who landed at their airports or that came to their ports, to measure their fever and to register who they were, and they had to tell which hotel they were staying at, and they could be easily tracked later. And seeing that we're a big global community of people that know each other, a lot of us know each other, it gets picked up very quickly when people make an innovation like this. And very quickly, this was built as a global package for COVID from our global development team that's now offered to many countries. And the package and this was possible because the technology is pretty flexible, and there is already existing knowledge about how to use the technology out in all parts of the world. And the software is also very well known in ministries of health, for example. So when they had to make a decision of, oh my God, how do we track COVID data? DHIS2 was an easy choice in a way, because it's something that's familiar to them. And it's something that can be easily supported because the competence is there. So it's maybe not that super easy to see on the picture, but the third phone from the left, the phone number 3 there, it shows the different programs that we support for COVID. we do make it able to for users to track index cases. So if, for example, if I test positive, I can be registered in this program to whatever follow-up you would need for a COVID positive person. You can also track lists of COVID cases. Once the caseload gets very, very high, it's very labor intensive to do detailed tracking of everybody, but it would still be interesting to understand more high-level statistics of how many cases do we have that has more of parameter A or B, for example. We also have a program to support contact registration and follow-up. So again, if I test positive, I would talk to some disease detective that would ask me, okay, who have you had dinner with, and who have you been speaking to, and who shares an office with you? And then they can also be registered in the system and be followed up according to some defined workflow that makes sense for this disease. We do the port of screening, or it's available to do port of screening, like I explained in the case of Sri Lanka, and also to pull out disease surveillance reports that are relevant for ministries of health, for example. And the software works on a range of devices, including Android devices, and that facilitates that you can work offline. So you can take this Android phone into the bush, and you can work completely offline, and then you sync back up once you're back online, which is good because many places that we work, the infrastructure is not necessarily very good. This map here shows countries that have adopted DHIS2 for COVID. We're operational in 19 countries, and it's under development and testing in 27 more countries. So it has pretty far reach very quickly, and I think that's very interesting to see how you can scale up something like this at this pace. We were just awarded money from the Norwegian Research Council to do research from the University of Oslo on this dynamic. How are you able to scale up a health information system in pandemic times to be changed? You have to set it up quickly, you have to get users onto the program and collect data very quickly. And then suddenly you have new guidelines from health authorities that now you shouldn't be interested in these parameters, you should collect something else. How do you work in a lot of countries very quickly? So hopefully some interesting results will come out of that. And also the fact that we have local teams on the ground means that we're able to innovate quickly because we know the software, it's pretty easy to configure, and it means that you can innovate on top of the platform and already define packages, so you don't have to start from scratch, but you can still adapt it to your local needs. So these pictures were taken, I think, this week in Uganda, where our team there has very quickly set up this traveler screening program because Uganda is a landlocked country with no they don't have any ocean around it, so all their goods has to come in by road. So even though they've closed their borders, a lot of on the border, and they're tracking name and symptoms, and they're printing out QR codes that they have to bring with them to the next checkpoints, and they know if the test points are positive, they can be stopped at the next checkpoint. And so they have a pretty good system in place to ensure that the disease doesn't spread too quickly in this for this use case. And I'm not sure if anybody read this article on Friday in Aftenposten, a big Norwegian newspaper. So the people in Norway who are doing this collection or trying to collect data about who has been infected with COVID and the contacts they have had with other people, it's in Norway at least, it's a very manual process. People use Excel sheets, pen and paper, post-it notes. So this has really been a case where the developing world or the developed world have been ahead of what we've managed to do here in Norway, and now we are learning from them. And that's a very interesting thing, I think. So we're not always at the forefront, but others have sort of paved the way and made systems that we now can use. And at the moment, we are piloting DHIS2 for contact tracing, meaning to figure out who you've been in contact with and following up and putting people in quarantine. in 6 Norwegian municipalities. So Bergen, Asker, Fredrikstad, Sel kommune, among others, are now piloting as we speak, trying to use it on real data. And then it will be, the plan is to scale it quickly to all the Norwegian municipalities that want to use this. So follow that space. Hopefully that will work fine. And then I wanted to say a little bit about how building these sustainable systems over time is really, really hard work. I'm sure, I mean, all of you work in IT, so you know that just getting the data in is a challenge. You can have as many fancy algorithms as you want on top, but just getting good quality data into the system is a big challenge in this setting. I put some pictures in here that are, I can explain what they are. Very often when we travel to places, the picture to the left, stacks and stacks and stacks of paper, is what meets you when you go into a hospital. I think this is the medical records in a hospital in Sierra Leone, taken a few months back. So, I mean, you're working often in a very analog world with analog routines, and then introducing digital technology on top of that is challenging. The project, they need to secure sustainable long-term funding. It doesn't help you see a lot of development projects fail because you're throwing lots and lots of money on it in the start when things are very, very urgent, and then the money disappears and the project just falls in the drain. You need to fit into this health information system ecosystem. What are in place, how do you deal with those, what do you integrate with, what do you import, what do you try to rebuild, and all the power struggles that surround that. There's a lot of work surrounding building local capacity. So you want to have like local teams that can support your system in country. It's not sustainable to have a Norwegian consultant or an American travel to the other side of the world to upgrade a server or to do other technical works. You need to have competent people in country, and also to train all the end users. And often in this high step we work, there is lack of power, infrastructure, broken devices, positions that are not filled, people that are not trained. You have people here in the picture in the middle in India where she has a tablet, she has no chairs or fans or light bulbs, right? So sometimes we want to introduce fancy technologies, and the very, very basics of providing healthcare is not there. So I don't know. There's always dilemmas, right? Of where do you spend your resources and what's sustainable over time. So now I've talked a lot about everything around this, but this was about machine learning and artificial intelligence, which we don't really do. But I was thinking through and talking to my colleagues what we thought were sort of possible or fruitful use cases for machine learning in our setting. And I think maybe one of the more important ones are, how do you ensure good data quality? Because data quality is crucial if you want to make good decisions based on the data. And we do have tools that can detect whether that does like simple statistical analysis on the data, and it will detect if there are outliers, for example, statistical outliers. You can see that this number is way too high compared to all the other numbers that you usually register, so this must obviously be wrong. But not necessarily if people are just entering random numbers that sort of fit. So I think you could probably do interesting things with looking at data and seeing if there are, for example, too little variation in the data sets. There should be more natural variation of the data that people are registering. Often we see that the incentives for submitting data from a clinic, for example, on time are higher than committing good quality data. So people are punished for not sending in the report. But if the report is of good quality, nobody really checks or rewards you for. Or if people don't see the need for the data, it's easy to make something up. Another thing that could be interesting for machine learning or artificial intelligence could be to improve predictions for thresholds for disease surveillance. So if you could combine other data sets from outside and understand what does it mean when a certain number is too high in this community or in that community. It might be different across a country, for example, across different countries, depending on other variables. And another use case that somebody mentioned to me was the use of chatbots to direct clients to available health services. I mean, the mobile penetration is very high in countries like this, and could you use it for directing people to available care depending on whatever complaints they come with. So that's a couple of examples, and I'm very interested in hearing you guys who work with this. If you have other good ideas, and you can also reach out later. We have a nice online community, community DHIS2.org, where there are several thousand members discussing issues around the use of the software. You can have a look at the code that's open and available to everybody. And I will sign up for your Slack channel so I can get your input there. Thank you.
Thank you so much, Anna. You can also post the 2 links, actually the 3 links in the chat, so yeah, people will actually already have access during the session. I think this is really interesting. I mean, as you mentioned, I mean, machine learning and AI are still on the future plan, but then as you also correctly pointed out, I mean, data quality is the foundational factor for good machine learning solutions.
Yeah.
And absolutely, in this session, we will also have Nicholas and also Bert later on sharing their solutions where they touch upon or actually utilizing more advanced machine learning already now for COVID. So that's something for the audience to look forward to. So I mean, since we're a bit tight on time, so I'm just gonna quickly pick up 2 questions for you. One thing is about the implementation of the project in Norway. So when will that be ready? And also, can you say something about the collaboration with Norwegian Research Council?
Yeah. So the first question was, when would it be available in Norway? So I would say, I'm not running the project, but I would say before summer is my impression. They're testing now and figuring out the good workflows that will finding the right compromise between a lot of different municipalities to fit a workflow that works for everybody. So yeah, before the summer is the answer for that. And the second question was the collaboration with the Research Council.
Yeah.
What the research project is about, or?
Yeah, maybe just briefly, what are you doing in the collaboration, so to speak?
Yeah. So for this project specifically, we have applied and achieved and gotten funding together with the Norwegian Institute of Public Health. So basically, the people that you see on TV who are giving advice to close schools or open schools, or the epidemiologists in the Norwegian Institute of Public Health, FHI, Folkehelseinstituttet. Together with partner countries in Ghana, Mozambique, Sri Lanka, and Palestine, who are all implementing DHIS2 for COVID. And we want to understand and learn more about how are we able to get requirements from the fields and quickly update a global software package that are then distributed quickly again back into the field. We know a lot about how we work with information systems in more sort of slow settings of routine information. I mean, children are immunized every year, every month, we know what's happening there. But when you're in a pandemic situation, things change a lot faster. So that's what we're going to try to learn more about.
Absolutely. Very exciting. Thank you again, Anna, for sharing.